Hey GP learners, and welcome to this episode where I'm going to be covering the RCGP guidance scoping document, talking about physician's associate in general practice, as we look at what the document says, what it potentially infers, and what impact it may have in general practice as we, as ever, tech enhance your primary care and learning. Hey GP learners, so let's get cracking by having a look at this document. So just to cover what's been happening. So over the past year or so, there have been significant changes in general practice. In particular, the role of physician associates become more and more to the fore. And obviously that's had impact in the way that people have looked at it. There have been various guidance documents coming out. So there's the BMA guidance that came out a few months ago, and many people are waiting to see what happens with the GMC guidance in terms of the registration aspects for physicians associates, which is due, many people believe, in December. Although there has been extra news on that if you've been watching the GP tabloids and everything else, in the sense that and other news outlets as well, actually, that the BMA have put a legal challenge to potentially the GMC, whether or not that will happen or not. I'm afraid I've not had time to look at that stuff yet. That's so hot off the press, we've not even had a chance to look at it. But today, what I am going to have a look at is the RCGP guidance itself, looking at physician associates. So if you want the link to that, that is down below in the show notes. And if you don't know how to get to that, well, this is how you can do it. So subscribe, make sure you click all the notifications, as well as the notify me for the video. It'd be great if you could like it, share it with your colleagues, and then if you want to see more details, click on more down below. And when you click on that more, you will see the link to this particular guidance that I will be covering today. Now, important to note that when you go to the guidance itself, there are various different aspects to it. In fact, there's three core parts to this guidance. So one where it talks about preceptorship, one where it talks about supervision, and then one which is the scoping guidance itself. And let me bring this on screen for you so you can hopefully have a look. And there you go. So we're starting off, first of all, with the preceptorship aspect of the guidance by the RCGP. When you go to the main page, it has a dashboard where you can look at these three different parts, but I've already got us loaded up onto this. In fact, let's see if I can get to the right bit to show you. No, I can't. Okay, I did have this up and ready, but we'll just carry on from here. So this is the preceptorship and induction aspects when it talks about physicians associates. So the introduction is pretty explanatory. It talks about things. It talks about the physician's associate role, and it talks about two key roles that the RCGP have clarified for us. So the GP Clinical Supervisor role, known as GPCS, and also the Educational Supervisor role, known as GPES. And these have different responsibilities when it comes to the physician's associates. It does make clear that the guidance that it's talking about is relative to England only, and in particular, the preceptorship program is an England-based scheme. It then talks about the utilization of physicians associates, and this document, so all the guidance that's currently in existence now, is for the next 12 months, and then the RCGP will monitor the situation and review this as it develops. And it does comment on this part that whilst it is RCGP's remit to enforce guidance, it may take into account NHS resolutions and other aspects in terms of how this will work, but ultimately it's the decision of the employers whether to follow the guidance, and it's the employer's responsibility to make sure appropriate treatment handling of existing PA contracts. Now, I think this is one thing that's really important to remember. This is guidance. There is always that question about how closely you need to follow guidance, and that is a challenging aspect when the guidance is quite significant. But there are aspects of this, and I'll be quite honest at this point as well, there are aspects of this guidance I agree with, and there are aspects of this guidance I do not agree with. But we'll come to that in a second. And if you've got comments on that, I would love if you can join me by telling me that in the comments below as well. So the first part about induction and preceptorship, it talks about pre-employment checks. This is pretty self-explanatory. Effectively, physician associates need to be on some sort of register to be confirmed. So there's either physician's associate managed voluntary register, or inevitably what they are looking at, which will be the GMC regulated register that comes into play. And I guess this is similar to, GPs being on the, what do you call it? It begins with P. It's completely gone out of my mind. Hopefully somebody can help me out in the chat and let me know what it is. I apologize. I'm having a mind blank, but I've got preceptorship just on top, and it's not that. Hopefully you all know what I mean, though. we're going to crack on unless someone can stick in the chat in the comments for me. But then it talks about induction, and this is an interesting part because it has clarified induction process. If I'm being absolutely honest, you could absolutely use this induction process for pretty much any role. Yeah, thanks. So Wildfires, thank you very much. Performers listed was the word I was looking for. I apologize. It's late. I've had a crazy day. So yeah, but there we go. But like I said, the induction process, it talks about, it very much makes reference to this being for physicians associates, but actually, if I'm being honest, this is a really good template for induction process for pretty much any role in general practice. So it mentions about a minimum induction of a 2-week period, which I think is absolutely sensible and recommended for majority of roles, unless they've already, I guess, been in that particular practice before. And it basically says to make available to patients and practice staff about the role and what then people might consult with a PA. And again, I would recommend that the same for any clinical role in practice, whether that's nurses, pharmacists, etc., GP trainees, HCAs, GP assistants, all those kind of things, having clarity for patients in terms of what that will mean. Basically that patients know who are treating them, because that is sensible and reasonable and things. It made to be clear to patients that they may ask to see someone other than a PA. I think that can be appropriate. I think a bit more clarity on that, because unfortunately I think there are different circumstances where sometimes patients ask for something that may not be possible. So I guess the flip side of that, I would say, is what if a patient asks to see GP and there isn't a GP capacity available? It doesn't really make clear on that part. And the discussion must take place. And again, I think that's reasonable to happen from there, as per the Health Watch suggestion and stuff. The practice to discuss with PAs rules and how PAs must introduce themselves to patients, and they must always be correct. Any wrong assumptions, they're not a doctor. I think, doctor is a protected title, so therefore, obviously, making sure that people understand who they are seeing is really important. Absolutely, things like name badges can help in this situation. Hopefully, you will have those in practice and things and stuff. The GPCS, GPES, and PA to prepare gap analysis and learning needs assessment. And again, I would recommend you do this with anybody new to practice. So we do this with our trainees when they start, in terms of understanding what areas are their strengths, their weaknesses, and what areas they need to focus on when it comes to their developmental process and education and things. And also this to be reviewed periodically. Recommends 3 months. I think that's, depending on the stage of training, that can be reasonable. I think if someone has been in practice for a long period of time, 3 months may still be a little bit optimistic at that point, and 6 months probably may be a better shoot at looking at that. But again, I think that's possibly a different situation. It does mention in the first year of employment there. On the basis of the learning needs assessment, GP, CS, ES, and PA to agree a job plan. Again, everyone should ideally have a job plan. It's modern HR process in general practice coming up for, so maybe we'll see more of that happening. In terms of understanding clinical competency, so that the things don't have to be repeated, I think we would all agree with that. We all hate having to re-justify why we're doing particular things. How many times during GP training did you have to show that you have, for example, know how to take a urine dip? Yeah, these are the kind of things that shouldn't really be happening. We're still, but so I think that having a record and some sort of log there would be useful. I must admit, I've not seen what types of portfolios exist for PAs to monitor and keep a track of that, and whether that's anticipated that people create their own versions of that, spreadsheets, etc. It'd be nice if there was some sort of unified document on that. And the PAs to settle into the practice to familiarize ourselves with the ethos, etc., and practice team to understand the role and how that fits in different to healthcare practitioners. I think that is sensible, because there is some differences that absolutely apply. And the PA to complete mandatory training, which, yes, I think we all get frustrated with at times, given the repetitive nature of it and stuff. But yeah, hopefully that is all sensible and reasonable in that sense and things. The PM is not commence clinical duty until agreed by the GPCS, and not normally due their first week in practice. Again, that's part of a parcel of an induction process. I think that's a really good way to look at things. The next part of this page talks about the preceptorship program. So it's recommending that all physicians associates should be doing a preceptorship in general practice in particular, and particularly ideally within their first 12 months of working and things. So this is kind of like a structured program to help them understand how to work in general practice. And it does make clear it must be a standard general practice kind of preceptorship, and not with a view to upskilling them to different roles. The formal program is currently only available in England, and it is and if it's not available, they recommend looking at developing something local in your area. It does recommend that the RCGP also suggests, protected time for supervision, frequency of meetings between the CS, the clinical supervisor, and the PA will depend on the experience, and also how to look at that, and also to recognize that because many GPs now don't work full time, that there maybe need to be cross cover that comes into process in terms of how that works and things. It does talk about the fact that some areas have mandatory trainings to support people in different roles, and particularly that may be available through your teaching hubs. Worth looking at that. And then talks about workplace-based assessment for the preceptee. So again, this is the part I'm still not quite clear on. I'd love if somebody has more details on this to clarify, but in terms of, what portfolio access and things people have, is there a specific one for PAs? Is it that they're anticipated to use things like 14 fish or that kind of stuff to keep a log of this? And it mentions that 3 months to do 3 case-based discussions, 3 mini kexes or carts, 6 months to do. I think this is the same amount. This part, I must admit, I'm struggling to infer whether that means 3 of these are 3 months and then another 3 at 6 months. But then it does say at 12 months to do an overall of 8 CBDs and 8 mini kexes over the year, which would put them in line with roughly what GP trainees are anticipated to do. It's not that far off in terms of that level of workplace assessments. But how to log that and stuff, I couldn't find any detail on that, and I would love it if people know about those. So that is the induction and preceptorship part. So this is the first part of the scoping guidance that exists and stuff. And then the second part focuses on supervision. So if no one's got any questions, we will move on to look at that. So in terms of supervision, this is a little bit more detailed in terms of it covers the concepts of these 2 key roles that were mentioned earlier. So the GP Clinical Supervisor and the GP Educational Supervisor and how these function. It does mention about the fact that physicians associates are part of the multidisciplinary team and that they need supervision from these particular roles. And that effectively this clinical supervisor is the person who manages and supports the physician associate on a regular daily basis in practice. The educational supervisor is more determined along their direction of development and training and how to support them in that way. They can be the same person where appropriate to do so. But ideally they should be, the clinical supervisor should be obviously within the practice that the person is functioning and working within. Again, it mentions about how the following guidance is going to be reviewed in 12 months. And it takes into account other aspects and things, and that this is guidance again. So governance when it comes to this. So let me show myself. So it does talk about how good medical practice highlights the governance aspects and things. And it talks about, let me find it, because here we go. So where you delegate care in line with the principles and your guidance, you are not accountable for the GMC for actions or omissions of those whom you delegate to. You remain responsible for the overall management of the patient, decisions around transfer of care and processes in place to ensure patient safety. If you prescribe based on a recommendation of PO or an AA, less relevant in general practice, you'll be responsible for the prescription you sign. Be sure that prescription needed, appropriate, and the patient is within the limits of your competencies. So it obviously there it states that you're not accountable to the GMC of the actions or admissions for someone who you delegate to. So you're not accountable if the physician associate has not informed you clearly or appropriately, or if they've omitted some part of the care. However, still when it comes to prescribing, there is still a relevant element of responsibility that comes into play. And I guess this part I would still apply to anything. We all know that you are always responsible for any prescription that you sign. That is no difference whether it's a physician associate recommending it, whether that's in some ways a secondary care consultant recommending it who's also reviewed a patient. Difference being obviously the knowledge base that comes from. But I think as ever, the key advice here is always if you prescribe something, you should always be aware of what you're prescribing, why you're prescribing it, and relevant reasons and stuff for that. In terms, it then talks about NHS resolutions perspective on some of this and how that will work. Where is the part I wanted to highlight? GP partners, principals, and other clinical staff responsible for the supervision of PAs within general practice are indemnified in respect of incidents involving physician associates which result in clinical negligence claim. So that's just here. Those brought against the partners or wherever there is a role incident involving the action of the PA resulting in claim was limited to the supervision of the PA. The scheme does not provide indemnity for cover for non-clinical matters, advice, or professional regulatory matters. So things like reports, which are non-clinically based, or other kind of documents on those lines and stuff, or obviously private work they would not be covered for and things. And obviously you still need relevant MDO cover outside if it's outside of the scope of CNSGP. So the GP Clinical Supervisor, let's talk about this role a little bit more. Okay, so in practice, PAs must always work under the supervision of a named GP supervisor, which is now known as their clinical supervisor. They're responsible for overseeing the work that the PAs are doing, and in clinicians and stuff. And the GP must also be available for advice to review patients and retain clinical responsibility for the patients that the PA has seen, irrespective of whether the PA seeks advice from the GPCS or not. So effectively, there is an element of responsibility that comes into play. And I think one of the key things it talks about is the ability to make sure that you are doing regular review of patients that are being seen by a physician's associate. They can delegate it to other qualified GPs within the practice, and so that's available to be done. And they must be on the JMC register in order for that to happen as well. And that's kind of sensible, isn't it? In terms of what should happen, let's be honest, you should be on the GMC register if you are a GP working in primary care. It's not appropriate, however, for locum GPs to supervise PAs because they need to understand the PA skills. So I guess people who are doing sessional work in that way, they may not be aware of the structures, process, and principles within the practice and things. A lot of P's there, isn't there? And trainee GPs must not undertake supervision of PAs under any circumstance. GP educational supervisors. So there will be a named GP who oversees the PH educational and professional development in consultation with the GPCS during the preceptorship period. And I would imagine that would also continue afterwards as well. They're responsible for making sure the induction happens, appraisal, etc., all those kind of things, and look at the knowledge gaps. And they can be undertaken by the same person as it says here. I'm just going to highlight that for everybody, especially in small practices. However, the ES role can be outside of the practice. So, for example, I'm an educational supervisor for some of our PCN PAs, and they're not based in my practice as a result of that. And I do more supervision around case-based learning, as well as directing their learning in terms of developmental opportunities and things. So yeah, I fit this last one that you may work in the same practice or in a different practice and likely part of the same PCN if working in England. Supervisor training. So this part's a little bit interesting. So the GP, ECS, and ES, and any GP delegate must have completed training in education and supervision prior to taking on the supervision of PA. Now, this part I think is sensible in some aspects. Unfortunately, it hasn't outlined the detail of what level of training that is required to be. And I think that's something that some people are having some confusion over, because is that dedicated training such as the level that you would do if you're a GP trainer to be a clinical supervisor, or is it a different level that is required? And that information hasn't been made clear in this particular document and stuff and things. So I think that's something where some clarity would be useful to move forward to. In terms of supervision arrangements, so the document then completes this by making it quite clear what the supervision arrangement should be. It outlines some of the stuff that's already been talked about. So supervision is delegated to a GP with responsibility must be available to provide immediate support for the PAs for at least the first 12 months in practice. Regular supervision time on a daily basis to hot review all cases. So ideally at the end of each clinic, or at the very least at the end of each day. To be honest, I would still recommend that should be clinic-based and not day-based. And that could be allowed to also review patients where needed. A weekly or fortnightly review meeting must take place between GP and CS to discuss areas of working. So I guess some developmental opportunities, and in-house reviews and protect time to identify interests, explore the development of longer-term goals, and identify those skills not currently used by or when their employment. This one I think is more, so almost to a degree more towards the educational supervisors' responsibility rather than clinical ones. It doesn't quite clarify that to me though. Notes must be signed off by the GPCS at the end of surgery day. I think there needs to be some documentation of supervision that should happen irrespective of the roles. So whether, again, that's the physician associates. I know for my GP trainees, every case that I review with them, I will also add a documentation of the fact that I've debriefed and reviewed their notes and things. I would highly recommend everybody does that anyway. And I also do that for all the other roles that I supervise, like our nurses, HCAs, etc. and stuff. There should be regular communication. Any clinical guidance by the GPCS and delegated must be documented. Again, that's the reason. There should be regular communication between those who are responsible for supervising PA, so all aware of the PA's progress. Yep, definitely sensible. And there must be a written protocol as discussed and understood in advance of the PAs to facilitate safe prescribing for patients seen by the PAs. We all know that particularly CQC love written protocols, and I agree there should be a written process. Everybody's doing the same thing. The PA will need to assess to authorize prescriber to either sign or prepared or generate a proposed prescription. Fair enough. Introductory arrangements as described in the preceptorship induction guidance must be followed so that patients know who they're seeing. PAs must not be moved routinely between significantly different environments and ad hoc basis as their training is not designed to support this and undermine supervision. Agree, absolutely. Moving staff anyway routinely is not ideal and should be ideally only done with people who are appropriately trained to do so. And there needs to be a consideration of a GPCS's job plan to ensure they have capacity to supervise safely. Again, yeah, this is all really sensible stuff, isn't it? In that sense, to some degree. Appraisal, annual appraisal for PAs must be mandatory and part of a contract between employer and PA. I think appraisals in general practice is one of the interesting things that many people find that they are very frustrating. I actually really enjoy my appraisal process, but hey, I'm probably one of those weirdo ones, aren't I? That or I really intimidate my appraisers. It's one of the two, I'm guessing. But I think, having an appraisal process for all roles within general practice is, again, like I said, it's one of these more modern processes of HR that's coming into fore. I think actually that's a really positive thing to be doing, and agree, that's something that needs to be looked at within the practice in terms of stuff that's doing. It does mention the FPA's appraisal document, which forms part of the FPA personal professional development, is currently used. I've not seen that particular document and didn't find it held within this, so I think that's something that needs looking at. So I'm just going to take a brief pause, see if anybody's got any questions on those two parts before we go on to the scoping document. I've got a load of people with us, apparently 88 people joining us today. So that's really awesome that there's loads of you with us. Still haven't quite got over the 100 yet, but hopefully we might get there. If you do have any comments or questions, do let me know. And just as we wait to see if any of those come in, I'm just going to load up the final and third part of this scoping document, which is the actual scope of practice itself. So in terms of the guidance, this is the one that I think I have some difference of opinion with compared to the RCGP, and we'll get to that in a second. I'm more than happy to take comments on those as we go and come to them and stuff. So in terms of the scope of practice, physician associate dependent healthcare professionals who in general practice work as part of a multidisciplinary team with supervision of a named GP supervisor. So that summarizes the role quite clearly there. The scope of practice guidance is couched in deliberately narrow terms for the following reasons: that patient safety is paramount and patient presentation is often complex, undifferentiated, multiple in general practice. The level of risk is uncertainties, diagnosis can be high, and there are few opportunities in secondary care to seek contemporaneous guidance from senior colleagues. I partly disagree with that last part. I don't think there's necessarily, again, this obviously comes down to your practice structure. I think there's always the opportunity to have secondary opinions, but I think it is in a different format and things. It mentioned about the limited research and evidence in general practice on PA's use and stuff, and that's fair enough. It's a new role to general practice, only been around officially for about 3-4 years, I want to say, although there have been PAs around for a lot longer than that. Obviously the PCN DES was one of the main progenitors for that. And the RCGP has heard sort of experience from its membership, which urged significant caution in the way PA is deployed in general practice. Okay. Document will be reviewed again, 12 months, and same stuff about guidance, indemnity, etc. and things. So it states that PAs must work within their scope of practice, which does not extend beyond the scope of practice in this guidance. They must also work within the scope of practice of their GPCS. So follow the documents, but also follow what your GP Clinical Supervisor says. PAs must always undertake a preceptorship program on entering general practice, and the completion which is prerequisite to working in general practice. The only part I have slight concern about that is those that have already been in general practice for a long period of time may not have done a preceptorship, because I believe the preceptorship did come out later than several GP based physicians associates have been working. So there might be some who've got several years experience in general practice who don't have that, and making them do that again just seems a little bit weird, to be honest, and lack of beneficial time and resources and things. PAs must always have had a period of induction at the start of their employment. Yep. And particularly if they're moving from practice to another. And I agree with that, because every practice is different. I think that's important to recognize and appreciate in those senses. And during preceptorship, PAs must be trained specifically general practice context. Yep. So general practice is absolutely different to secondary care. So I don't think that they apply in the same way. PAs must always have a GP Clinical Supervisor. They're responsible for scope of practice and employment, etc. And also have an educational supervisor. And this can be the same person, and they should be filling in their studies and what they're doing. PA must not undertake activities outside the scope of practice documents, even if they have previously undertaken those in non-PA role. So this could be a bit irrelevant, because there have been some clinicians who have changed their job titles and stuff, and therefore previously done other roles where they could have seen patients, but because they're working as a PA, important to remember that they are working as a PA in that sense. PAs, so for example, you can't have, you could potentially have a situation where somebody has a prescribing ability, I guess, but it can't, because PAs currently aren't allowed to prescribe. I don't know if that's possible. Maybe I'm making that up. PAs must not see patients who have not been triaged by a GP and undertake work delegated by them and agreed with their and only undertake work delegated by the GP CS. So I agree with that. I think, having triaged work coming through is important, and understanding what the scope of what each clinician is doing. Actually, I think the concept of triage, as many of you probably know, is quite a powerful one in general practice in particular. So knowing what you're dealing with before you open the door, in a sense. And I think that's, an appropriate step to be looking at. Practice of clear protocol in relation to triage process. Well, yeah, you should do that. And protocol should be incorporated to patient preference around the healthcare professional that they see. I think that part I have slight concerns, because actually patients don't always know necessarily what they need to see, particularly in the skill capacity mix of the practice. And I think, my perception on that is that, often patients don't know what a practice has or capable of have, and what people can do as well. And the amount of education time it takes to do that on an individual patient basis is not realistic in certain situations. However, I do think it is also appropriate that, patients have absolute understanding of who they're seeing, which is what the next couple of sections talk about, in terms of the roles need to be visible on the website and accurate. Because I know, unfortunately, there have been historical aspects in some practices where people have not been clear about the roles that people have, and that has clearly caused issues and concerns, and it's, a probity issue, to be honest, as well, if it was done intentionally. But yeah, so website, there needs to be clear direction and description of what people do. Members of staff must wear name badges, etc., and stuff to identify that they are PAs and understand to explain to patients who they are. It mentions that PAs must not be the sole health practitioner on call or duty direction, and they must not see walk-ins. They've not been triaged by a qualified GP. I think that's reasonable. I think, again, there's a difference between one of the things this guidance doesn't make clarity on is for those physician associates who have been working in general practice for several years and potentially have more detailed and training and experience that has been focused along the lines of what the guidance actually says, to be able to do that. This very much seems like it's written for newly qualified physicians associates, which is majority, absolutely. But this part, I think there are some flexibilities potentially in that, but I agree with a lot of what it says there already anyway. PAs must always use the GP practice clinical guidelines and protocols. Yeah, well, we all should. PAs must always document care and advice they've given, and including any information shared on behalf of the patient's GP and any members of the primary care team. Notes must by any encounter must also include any advice given by GPCS, must be signed off by the GPS at the end of the day. Yep, and there's some supervisory guidance documents in that as well. Promote evidence-based medicine, yep, and should engage in activities such as clinical audits. Must have a formal annual appraisal, which we've already covered. And in light of the arrangements, supervision, triage, and scope of practice, we do not consider it currently viable for PAs to be employed in the out-of-hours settings or as locum PAs. So I guess to answer Walzaf's question, how does this work for locum PAs? According to the guidance, can't really have a locum PA, the way that it works and stuff. So if there are any locum PAs currently joining us, let me know. But the guidance suggests that that should not happen currently. The induction, supervision, ongoing training of PAs should be available to CQC inspection to ensure patient safety being observed. Well, to be honest, that's the case for everybody in general practice. So there we go. Then talks a little bit more about this whole concept of first point of contact, undifferentiated patients, clinical triage, and the clinical aspects of each roles. So this is where I have some reservations about the guidance that comes through, and we'll come to those again, like I said, in a second. It does mention the PA must not see patients who have not been triaged by a patient and undertaking work delegated by them. Now, one of the things I think that this guidance hasn't taken into account is that there are currently systems and processes being used in general practice that actually automate some of these things, and that can be factored into. So this does have an issue, I think, for some providers who are currently supporting general practice, where actually that breaks their systems and that doesn't quite fit. So I think already to a degree, this guidance may be slightly out of date, bearing in mind it only came out a couple of days ago, but it hasn't taken into account the breadth of some of the things that currently happen in general practice. So I think in that sense, I have a slight frustration with this, in the sense that, you know, there are already clinical systems and processes and you know, for example, triage protocols that practices have created. There are triage providers that have created autonomous aspects to support patients and get them seen by the right patient at the right time. That don't fit necessarily with that, but are built in a sense to follow that. So I guess there's just, you know, if we are following guidance to the letter, that wouldn't apply, and that makes me a bit concerned as to how that's going to work. But I guess, you know, if you've got clear protocols as it mentions, then that's relevant. But this makes reference more about patient preference, and again, I've made comments on that already in terms of my perspective of that. PAs can take histories, do an exam, construct potential diagnostic and management plans, and that can be shared contemporaneously with the clinical supervisors, and then review if needs be at the end of the session, or more, you know, can be later if that's safe to do so. So I think, you know, that's a nod to recognizing experience in certain PAs and things. If a patient presents with a new issue during the consultation, the PA may be able to take a provisional diagnosis depending on the scope of practice, but then must present the case to GPCS. Yeah, fine. If a patient contacts the practice a second time, the same unresolved issue, they must be triaged to a GP. I think that's clearly with the safety in mind, particularly following some of the recent cases that we've seen. To be honest, that's generally a good rule of thumb that most of us have. I think, you know, if it's seen one person from, you know, an AHP and it's presenting about the same issue, then generally speaking, that should be having a review, ideally with a more senior clinician, or if that's relevant and stuff, or, you know, another clinician for perspective and things. I guess in general practice, most people tend to rule by the rule of three. So third presentation, you need to be asking for another opinion. This just brings it down, I guess, to a second contact, sorry. And PAs must not be given responsible of clinical triage or undertaking clinical triage. I guess, you know, for me, I do have issue with that, because I know that in my practice, we have trained PAs to do that previously. That's not currently the situation. In our practice, we've changed our complete model that we have. But I am aware that we spent quite a long time training people to triage people effectively, and that worked quite well when we were doing that role, and that was after 6 months of training additional on top of the roles that they had. So I guess, again, it doesn't take into account some of the existing work that's already happened in general practice. So let's have a look, see how we're doing. We've got some amazing stuff going on. So just as a point out, we do have more than 100+ live viewers. So hello, everybody. Hope you're doing all right. It's clearly a hot topic for many of you, but would love to see some more comments from you coming through and what you're thinking on this. So let's talk about some of the contact presentations. So one of the key things it mentions is about first point of contact presentations for adults who are greater than 16 for suspected minor or common in conditions. So basically referencing the 7 minor illness things as based in pharmacy first, that would be in scope. And basically anything outside of that should not really be covered. Again, I have an issue with the age limit. I think there should be some flexibility around that based on training. For example, what about a 15-year-old with acne? I think I would be perfectly happy for an experienced PA to assess and manage and support that condition. But obviously that's not taken into account. I think there absolutely is age limits appropriate in terms of how people assess cases and stuff. And again, that needs to be individualized based on the training and support that they've had and the role and experience that they've had as well. I also don't like the way that they typify things by abdominal pain and headache, because actually they are variable symptoms. And again, once they've been already pre-triaged, you surely have some information on those conditions beforehand. So it kind of not clear. You know, abdominal pain can be a variety of things. Headaches absolutely can be a variety of things. And I think that's part of the challenge with it because of the flexibility and the openness that comes into it. But also, I think if they've already been triaged with a view for having a clearer understanding, and again, it comes to the depth of that triage, I think, then actually that has some flexibility in my mind in terms of what those things can be seen and how they can be seen. It talks about mental health issues that they should not be seen by PAs. I think it doesn't quantify what mental illness exactly means. And I think there's an absolute difference between somebody feeling slightly anxious, which could be considered as mental illness, and maybe anxious about the way they're presenting, versus somebody with significant mental illness, you know, psychosis, etc., and things. And they are completely different things. And actually, there's a breadth again in terms of what we see and experience and things. It mentions again about under 16s being out of scope. As I mentioned, that age limit I don't feel is appropriate for everybody. But I agree in the sense that, you know, not doing baby checks, and actually, I'd probably say the minimum age should be 5-year-olds at least. For most people, you know, anything under 5 shouldn't really be seen by AHPs unless they have been suitably trained to do so and things. And I know obviously a lot of AMPs will, for example, see up to 2 years, but generally not see under 2 years, for example, and that's after a different level of training. PAs must not be triaged to see women who are pregnant, postnatal, or have suspected gynecological problems. Definitely agree with the first two, less with the third. I think certain gynecological problems may be different, but then again, I'm not an expert in this. I'll be honest on that. You know, I don't understand the full competencies in those kind of aspects. Multimorbid, management of patients with complex multimorbid issues, complex rare disease, and severe frailty. Yep, I think that's understandable. There are so many complexities that come into play with that multiple health issues can be really challenging. PAs must not be given urgent or routine home and care home visits to do. I agree with the urgent ones. I think routine, I think that's a different aspect, because a lot of that can often be about data information and capture rather than necessarily treatment and management. And again, the guidance doesn't take into account structured processes, protocols, and things that can happen and things. I mean, I know many places where they've had medical students, for example, go see patients, and we're talking about medical students in year 1, year 2, for example, in care home ward rounds and things. So that would be no different in sense in training in that aspect and things. Obviously, that's still with a learning hat, so not necessarily a treatment hat, but the information gathering aspect can be similar, if not that dissimilar and things. PAs must not initiate or complete end-of-life discussions with patients. PAs must not prepare end-of-life documents, DNA or CPR respect forms. So I agree with the last two, because obviously that requires a level of a process and things. I think, you know, if those discussions come up during the consultation, it's a bit hard to say, I'm not going to talk about this with you. So I think there is, again, some element of flexibility, but they should not be the end point of that discussion, in my personal view. PAs can give contraception, sexual health if trained to do so. Yeah. PAs must not see patients with learning difficulties. I think this one personally needs to be in this box, because I think there's a different aspects that can be delivered through that role. I think they should not ideally be done at the point of newly qualified. I think probably a lot of the issues I have with some of this particular part of the scoping part is that I think many of the things should be more in the middle box, which is the box that says can do with extra training, rather than completely out of scope. But again, not an expert in this. I'm not the person creating these documents and things. PAs can give advice on travel vaccines, general health travel if trained to do so. PAs may suggest review changes to patients' existing management plans and suggested changes when they've been reviewed by a GP, and can support single long-term conditions along NICE guidance and algorithms. Absolutely, I think that's sensible, particularly with training. PAs can perform HRT reviews if trained to do so, and talks about talk about side effects and contraindications. PAs can undertake annual health checks and provide lifestyle support according to proposed protocolized pathways, but mentioned not doing so with patients with learning difficulties and severe mental health issues or other complications. Again, I personally feel this one should probably in this box. Again, I'm not an expert. PAs can undertake immunizations if trained to do so. Yeah, I think if we've had general public vaccinating patients, then I think that's sensible for things like flu, etc. COVID, we obviously had. PAs must not administer steroid injections or intra-articular injections. Again, I don't know if this can extend into this box with suitable training. It comes down to the depth and level of training, I think, that comes with that. But again, previous comments apply. Undertake minor surgeries, similar, maybe. I don't know. I don't do minor surgery, so I don't know, and I can't comment on that, I'm afraid. PAs can do smear tests if trained to do so, and current registration on relevant national sample register. I guess this is why I had issues with the gynae stuff earlier. So it mentions here that they can do smears, but they can't do gynae conditions in the same way, which again slightly confused me because it's a similar examination and process and things that comes into play. So IRMA guidance applies here. I mean, that's the case for many additional roles anyway, in terms of ionizing radiation and things. PAs can do spirometry tests if appropriately trained, can do point of care tests, and can do ECGs if trained too. So similar to HCAs and other roles that would do that. Interpreting tests, PAs can interpret test results as part of NHS health check, discuss the results with patient, offer advice and the way to make lifestyle improvements and where protocols exist, but must not analyze diagnostic tests in an area not covered in NHS health checks and where practice protocols do not exist. So basically anything outside of your standard health check and things. And they must not interpret ECGs. To be honest, I think many GPs struggle to do that at times. So maybe not. And then referrals, it talks a lot about how PAs can do referrals. I think one of the interesting, I actually found this quite supportive, because one of the challenges I know I've had locally is that some of our local departments will not accept a PA referral, even when it's been agreed and reviewed and even instructed by a GP locally. They still insist that the GP physically actually has to do the referral, which I don't agree with. I think if it's been so, I've had situations where patients I've reviewed and I've asked the PA to do the referral because it means I can see other patients who are needing attention, and I've had to go back and actually physically do the referral because they refuse to see them. And that's basically where some of this guidance I think is actually quite helpful in clarifying that it can be done when it's been approved by a GP and stuff and things relevant, and that they can do similar for safeguarding referrals, etc. Mentioned that they can't prescribe. That's currently the case. Absolutely, prescribing is a different level of training that comes into play in terms of the ability to do so. And then it talks about completing forms in practices, so insurance reports, discharge summaries, and in line with practice protocols, other kind of documents that they can be done with training, but they can't do cremation forms, which actually don't exist anymore. So, like I said, partly this guidance is kind of out of date, but it does mention that where they're still being used, but they no longer exist in the UK, I believe. And not sign fit notes currently. That's again in line with the current guidance, which is 4 clinical roles, which is GPs, physiotherapists, practice nurses, and pharmacists. And must not complete child protection forms either. Yeah, fine. PAs can be involved in an agreement or partners in terms of teaching and learning, and doing a lot of the educational aspects, and involved in wider practice initiatives, green, etc., outreach. Experienced PAs can do some of the teaching of student PAs with the agreement of GP supervisors. PAs must not supervise, manage, or be responsible for debriefing after a patient contact members of the MDT, and PAs must not teach or supervise or take debriefs of GP registrars, foundation doctors, medical students. Yeah, I generally agree with that. I think there's particular instances where I think that can be appropriate, but that is much more smaller kettle compared to, I guess, the other ones that we've seen and things. And particularly in terms of practice policies and processes, I think that would be actually quite sensible to go through if they're more okay with them, because as we've covered, they've probably got a lot of the experience in terms of understanding those with the induction process and things that happen. So, been through there. I will summarize a lot of that afterwards into timestamps and stuff for people to have a look at, but I would love to know if anybody's got any comments or questions that they have in terms of what does that guidance actually mean for you functioning in general practice. Do you agree? Do you disagree? What are your thoughts in terms of that? You know, I would love to know what people are thinking on that. I guess I've been quite honest, I hope, in terms of discussing some of this. So, you know, I think the guidance is useful in some ways. It clarifies a lot of stuff, and particularly the induction and the supervision guidance is very helpful at clarifying some aspects I think many people wanted. I would have liked a little bit more detail and clarification on some of the aspects, like, for example, what is the educational level that people need to have if they're supervising a PA in practice, as suggested by the RCGP. I've been quite honest that I don't agree with some of the aspects of the scoping guidance. I think more of it should be in the middle column in terms of with appropriate training and stuff. And I think particularly the guidance, it doesn't take into account people who have been working and experienced in general practice in safe and appropriate ways. And I think for that reason, some of it has been designed to be almost unworkable for general practice, which is probably what I think some people were hoping for. And I can understand why, because I think there's a lot of emotion behind what some of the guidance means as well, but in terms of general practice and stuff. But yeah, that I think is pretty much the document itself. There is, as I mentioned earlier, further likely changes that may happen in the near future, in particular the big one that many people are anticipating is the GMC guidance and how that will work in terms of registration of physicians associates, which, you know, has been a contentious issue in the way that that may happen, because I think there should be a separate register if that was to occur, and that it shouldn't be the same register as doctors, because that does confuse the matter for patients as well, even further. But should they be registered? Absolutely. I think, you know, physician associates should be registered, so then that's clearer in terms of line of responsibility and how that will work and things. But I think the process does need looking at and things. If you've got any comments, do let me know down below in the comments as we've been going across. I hope you found this episode useful. If you would like more guidance documents like this, let us know as well, because I think there are further things that are likely to come. Myself and Andy will be back shortly in a couple of weeks' time to go through more things as ever. Alternately, you're welcome to join myself on this episode that's coming up shortly, in fact, tomorrow, believe it or not, on the use of AI in general practice, and how that will affect basically everything that we do as we continue to tech enhance your primary care and learning. Catch you next episode.